For those of you who don't know me, I'm Christine Barker. I'm a nephrologist and a medical educator, and I wanted to come on and do this little session today. Honestly, it was a very spontaneous decision this morning when I woke up. I thought, I wonder if I should try YouTube Live today, and I picked this topic because I think it really is a pain point for trainees. It's something that I think is hard to learn, but it's actually super easy when you unpack it. So I'm hoping that that's the experience that you find today. So this shouldn't take too long, hopefully no more than sort of 20 minutes or so, but obviously it depends on how much fun we're having. So, and thank you so much to those on the call, and also welcome to anyone who catches the replay as well. So in terms of aldosterone physiology, a lot of this will be familiar to you, but I think it's always just great to do a bit of a refresher. So the first thing to appreciate is how everything really kicks off in the juxtaglomerular apparatus, which is this little part of the kidney, the little nephron, where the distal tubule kind of meets the afferent arteriole. So it's a part of the kidney that is monitoring blood flow at all times. It's monitoring the little mini pressures inside that afferent arteriole. And if this part of the kidney detects that there is low blood flow, it's going to release renin. And of course, renin changes angiotensinogen into angiotensin 1, and then that's converted in the lungs into angiotensin 2. And so if we truly had low blood pressure, then angiotensin 2 would help us to improve our blood pressure in a number of ways. So it can cause vasoconstriction all in its own right. And it can also promote aldosterone, which is, of course, what we're talking about today. So aldosterone is made in these little adorable adrenal glands, and it has two jobs within the nephron. So the main job and the purpose of this whole hormonal axis is to reabsorb salt and water when we are dehydrated. That is the main job. That is the day job. And that's going to take place inside these little principal cells. So aldosterone is going to bind to its receptor, the mineralocorticoid receptor. And when it does that, it's going to change the intracellular signaling and then the DNA transcription and translation. So it's actually going to change the channels and pumps that are expressed by this cell. And there are three main channels or pumps to be aware of. So one is the epithelial sodium channel, which is on the tubular side of the cell, and also the potassium channel, ROMK, which again is on the tubular side. And then on the basolateral or blood side, we have the sodium potassium ATPase. So all of these are going to be increased by aldosterone. Now, these all work together, which is key to understand when you're coming at the sort of the biochemistry of aldosterone. If you understand these channels, you've got it, you've nailed it. So basically, the sodium potassium ATPase, no matter where it is in the body, it's always doing the same thing. It's going to be actively pumping sodium from the cell to the outside of the cell. And the reason it's doing that is to create a concentration gradient. So if it moves sodium out of the cell, what's going to happen is that inside the cell, there's going to be a very low sodium concentration. And that is ideal when sodium comes along into this tubule, into the collecting duct. There's now a concentration gradient for its reabsorption, right? It's high here and low inside the cell. So that sodium is going to move through this little sodium channel along its concentration gradient and be moved to the other side. And this sodium potassium ATPase, as it moves sodium inwards, it will exchange that sodium with potassium. And the potassium has to have somewhere to go. So we use this little potassium channel to get rid of it. And so as we take in sodium by this mechanism, and therefore water, because water follows sodium, we will lose potassium. So a very key point. And of course, under normal circumstances, if we have then reabsorbed enough salt and water that we've gained homeostasis, this whole hormonal cycle there'll be negative feedback on renin, basically. So once we've got enough salt and water reabsorbed, then we won't have to make as much renin, and the whole thing will just switch off and go back to normal. But I mentioned that aldosterone had two jobs. The main one was that salt and water retention, but it also does one more thing. It has a side hustle, and that is all about getting rid of hydrogen ions. And that happens in these little intercalated cells. And what aldosterone does there is it promotes the insertion of these little hydrogen pumps and pumps hydrogen out into our urine. So aldosterone has those two jobs, salt and water retention and acid-base homeostasis, namely getting rid of hydrogen. And we said as sodium comes in, we lose potassium. So given what I've just said to you, I want you to commit to your answers. You don't have to speak to me if you don't want to in this very public forum. You could write in the chat box if you want to, but what I want you to do is to really commit for yourself to the answer to these questions. So what biochemical patterns might you see on the blood test if you had aldosterone excess or an aldosterone resistance or deficiency? I'll just give you a moment to write that down. Or you can talk to me, up to you. If anyone's talking to me on YouTube, I'm sorry, I don't have another screen and I can't see you. But I love if you're talking to me on YouTube, just in the Zoom room. Oh, amazing, Jay. Too much aldosterone, too much sodium in, potassium out, acid out. So hypokalemia, metabolic alkalosis. You are a ninja about to do night shift. Ninja. So aldosterone excess, yes, too much aldosterone, exactly. We're going to rev up this whole process, which means we're going to lose more potassium. And we're also going to lose more hydrogen ions, so we're going to have an alkalosis. And then if we have an aldosterone resistance or an aldosterone deficiency, the opposite is true, right? We'll have that high potassium and we might have an acidosis, particularly a normal anion gap metabolic acidosis like an RTA. And so I'm not going to talk about renal tubular acidosis today. And I gave you guys a YouTube video last week on RTA, so you can definitely check that out. But I guess just to link this all together, to remind ourselves that aldosterone deficiency or resistance is the cause of type 4 or hyperkalemic RTA. That's all it is. So just to bring all that together for you. And one of the key ways that we have aldosterone resistance is iatrogenic, right? It's the drugs we use. It's these potassium-sparing diuretics. So the next thing I want you to tell me is there's 4 different diuretics that I can think of that are in this tube anyway, 2 of which block aldosterone at its receptor, at the mineralocorticoid receptor. What are the 2 potassium-sparing diuretics that you know that work here at the aldosterone receptor? Spironolactone, yes, we've got a unanimous. Well done, Kate and Evelyn. Yes, loving your work. Yes, perfect. That's right. So spironolactone and eplerenone both work at this receptor. So they're going to be quite potent, aren't they? They're going to block all of these channels from being inserted. So they're quite, I guess, they're global in their effect in blocking aldosterone. Now, which diuretics block just the sodium channel here, just this epithelial sodium channel? Amiloride, yes, amiloride. Beautiful. So amiloride, and the other one is called triamterene, which, to be honest, I don't know if I've ever prescribed that ever, but it's on up to date and in the literature. So you might come across that at least when you're reading. But amiloride is the one that I've definitely prescribed in practice. So it blocks just this channel. It's not blocking it at the mineralocorticoid receptor. And I guess something else that just to be aware of here as well is this little ENaC channel. This is also the channel that lithium would use. So it's a little bit by the by. I didn't actually plan to talk about this, but why not? So lithium and sodium look a bit like each other. And so if you're in a situation where you've got lithium toxicity, it's often because there's a lot of lithium that's been absorbed in here and it's causing toxicity inside the cell. And that's promoted by dehydration because the body's trying to absorb sodium and instead it absorbs lithium. And it's happening through this little channel. So sometimes amiloride is used to help with lithium toxicity because it blocks this channel as well. So a wee bit of an extra for you. All right, so another really fun thing that I've created for you guys. So you'll see in the chat box, either on YouTube or in the Zoom room, I've put at the top of the chat box a link to this exercise. So what I want you guys to do is to click on that link and then do File, Make a Copy. That'll make your own little Google Doc. And then what I want you to do, once you've done that, is to drag these arrows onto this table. So whilst you do that, I'll just orientate you to this table and let me know if you're having any technical issues. But basically, we're going to go through all the different types of hyperaldosteronism. So there's primary hyperaldosteronism, which is when the adrenal gland is kind of doing its own thing and it's secreting a lot of aldosterone. Then we've got the secondary types, and there's two different types of secondary hyperaldosteronism that have slightly different patterns. One can happen in salt wasting disorders, such as Barter's or Gentleman's syndrome. So basically, they have trouble holding on to salt and water. And there's also the type that happens in chronic renal hypoperfusion, with the example being renal artery stenosis. Now, when we come back to feedback on this table, I'll go through them in a little bit more detail. But what I want you to do is just have a go at trying to put these arrows onto the table. I'll give you a couple of minutes to do that, but let me know when you're finished. Let me know how long is enough time. I'll pop a wee timer on for, say, 3 minutes, but let me know if you finish earlier than that. Okay. How you guys going? Are you finished or need more time? Thumbs up from Jay. Perfect. Okay, beautiful. Just minimize this. Lovely. We're going to go through it anyway, so you can continue to move your little arrows around. In terms of the answers to this table, so I guess when you're filling this in, of course, we're talking about hyperaldosteronism. So all of them have high aldosterone, so easy. That part's easy. I'm going to focus in on secondary hyperaldosteronism, but to this salt wasting disorder first of all. So this is kind of the closest thing to a physiological response. So although there's a pathological disorder that's causing it, it's kind of physiology in motion, right? This person is trying to use these mechanisms to stay well. So in these salt wasting disorders like Barter's or Gentleman syndrome, basically, in these genetic conditions, there's a problem with their sodium channels or transporters, which means that they're not going to be able to reliably reabsorb salt and water. So Barter's behaves a little bit like furosemide toxicity, and Gentleman's behaves a little bit like a thiazide toxicity. And so they're losing salt and water, and this mechanism is going to help them to try and hold on to it. So they're losing salt and water against their will, and the kidney is going to clock onto this and increase the renin. So the renin is driving the high aldosterone. Because the aldosterone is high, the potassium is going to be low. And in this situation where the person is trying for dear life to hold on to their blood volume, their blood pressure is either going to be low or low normal, but it's not going to be high in this situation. Now contrasting that with primary hyperaldosteronism, so this is when the adrenal gland, for whatever reason, is just chucking out aldosterone. It might be due to an adenoma, like in Conn syndrome, or maybe adrenal hyperplasia, but the adrenal glands are just chucking out aldosterone for no reason at all. So in that situation, you're going to have a suppressed renin because it's not happening due to renin. Renin is trying to shut this off, right? We have lots of blood volume. There's no need for the renin. And so the aldosterone is high, but the renin is suppressed. That is classic of primary hyperaldosteronism. And again, because the aldosterone is high, we're going to have low potassium or sometimes annoyingly normal potassium. So it's very possible to have primary hyperaldosteronism and have a normal potassium. So it's not a deal breaker, and you should still remain alert to this possibility even when the potassium is normal. But of course, if the potassium is low, it's going to be a helpful indicator. And in this situation where we have unregulated aldosterone continuing to promote salt and water reabsorption, we're going to have high blood pressure. So that's the answer to that one. Now, coming back to this secondary hyperaldosteronism, but a slightly different mechanism, is chronic renal hypoperfusion. So this is when the kidneys think that they don't have enough blood supply, but really they do, right? So this person could be potentially very fluid overloaded. They've got lots of salt and water on board, but the kidney thinks that it doesn't because the actual perfusion to the kidney is low. And so that can happen in severe renal artery stenosis, or the other classic is heart failure, where you've got that kind of low cardiac output, and so the kidney perceives a low blood volume, even though truly there's no blood volume issue. So in this situation, the kidney is perceiving a low blood volume, it ramps up renin and promotes aldosterone. And in that situation, we are going to have a high blood pressure because of all that salt and water retention. And in this situation, we don't tend to have a low potassium. It does tend to sort of balance itself out. So more often than not, in the chronic renal hyperperfusion, you'll have a normal potassium. But just to reiterate and really sort of make sure that we can remember this for MCQs in doctor life, is if you see a low potassium combined with a high blood pressure, it should really alert you to the possibility of primary hyperaldosteronism. We should always have that top of mind when we see that combination. So now I'm going to stay on aldosterone excess, and we're going to talk about the aldosterone renin ratio, because I know that this is a point of confusion, but it's actually, you're going to find this super easy after this next few slides. So we're going to answer 4 questions here. First of all, why do we perform the aldosterone renin ratio? Then, how do we do this properly to maximize the accuracy of the test? How do we interpret this ratio? And what do we do when it's positive? So I'm going to break it down. So question 1, why do we perform the aldosterone renin ratio? Basically, this is a screening test for primary hyperaldosteronism. That's all it is. It's for this one specific condition, and it is a screening test, not a diagnostic test. And it's a very important test to be aware of and to request when we need to, because undiagnosed primary hyperaldosteronism is associated with a much higher cardiovascular risk and end organ damage compared to just having high blood pressure on its own, right? So having this high aldosterone does tend to lead to scarring and damage to the organs, much more so than just blood pressure by itself. And the other thing is, it's potentially curable. If you can find this in a patient, you could potentially cure them. They might not need a blood pressure tablet ever again, if you catch it early enough. Now, we usually do the screening test as part of the secondary hypertension screen, which means that we're looking for a fancy cause of blood pressure, usually in someone who's young, who has hypertension, or who has very severe hypertension or resistant hypertension where they're on multiple agents. And of course, if you do see that combination of low potassium and a high blood pressure together, then you definitely want to do this test. Of course you do. But equally, you could justify it in just about anyone with high blood pressure. And if you did it in just everyone across the board, you would actually find this in 5% of patients. The proportion is going to be higher if you're doing it in the people I've just mentioned that sort of want a secondary hypertension screen, but you'll find it in people who you'd otherwise think would have essential hypertension as well. So how do we do this test properly? So say you had a patient who needs a secondary hypertension screening, you're going to perform the renin-angiotensin-aldosterone ratio. Sorry, renin-aldosterone ratio. What we need to do is make sure that they're not on either not on medications at all, or not on medications that would interfere with this test. And on the next slide, I'm going to take you through the medications that are okay to use with this test. So we need to think about their medications, and then depending on what medications they're on, we want to keep them off them for either 2 to 4 weeks before we do the test. So 4 weeks would be what we'd recommend for, say, like spironolactone and those potassium-sparing diuretics, whereas other things you might get away with 2 weeks. So 2 to 4 weeks is the recommended time interval. We're going to recommend they just eat normally, so have a normal amount of salt in their diet. What we don't want them to do is restrict their salt, because that could upset the test. And we also want to correct any low potassium that they have. So even though the aldosterone excess might be causing that low potassium to be there. Ultimately, potassium and aldosterone are in a bit of a feedback loop. So the fact that their potassium is low might be having a negative feedback on aldosterone. So what we want to do is correct the potassium, make the potassium normal so that nothing is suppressing that aldosterone. We want that aldosterone to be the maximum amount on the day of the test. So we'll reduce false negatives by doing that. And then we want to perform this test at about 8 o'clock in the morning when aldosterone is apparently at its peak. So coming on to those antihypertensives, do you guys actually know this? I think it'd be interesting to see if you already know this, but what antihypertensives can you be taking that won't interfere with this test? Can you give me some names? Don't worry if you don't know it, just keeping you with me. What BP meds are okay? Hydralazine, yes, that is one. Yes. Any more? You're all over it. Amlodipine is one of them. To be honest, amlodipine it can interfere with the test, but it has a very low probability of interfering with the test. So some people do use amlodipine, but the way I'm teaching it today, we're taking amlodipine out. But you're right, it's got a minimal effect. You can sometimes get away with it. Yeah, you guys have got great ideas. So these are the drugs that are recommended in the literature. So hydralazine, you guys mentioned. Doxazosin is very similar to prazosin, and I think prazosin would also be okay. Verapamil is also okay. Now, basically all of the other blood pressure medications could impact this test. So you can get false positives with beta blockers or centrally acting blood pressure medications like clonidine or methyl-dopa. And you can get false negatives with RAS inhibition. Amlodipine has it's less so, but it can cause these false negatives, and diuretics, of course. And it's much worse to have a false negative than it is to have a false positive, because, for example, if you have a false positive, at least the screening test is positive, and then you'll go and do more investigations and you'll get to the bottom of things, right? Whereas a false negative, you'd be at risk of not exploring the diagnosis and missing the diagnosis. So like avoiding false negatives would definitely be a priority. So like I said before, ideally you'd have them on no medications if that was safe. It's often not safe. So what you would do is transition them onto these tablets, wait a few weeks down the track, and then do your test. So once you've done your test, how on earth do you interpret it? So basically when we do the aldosterone renin ratio, what we're asking is it high or not? That's basically it. So all we're trying to get to the bottom of is the aldosterone high and the renin suppressed? Because that's going to give you that high ratio, right? Because we said before when we did our table that is the pattern of primary hyperaldosteronism, and this whole test is designed to screen for primary hyperaldosteronism. So all we're asking is this high or not? That's it. And if the ratio is high, you now have a positive screening test and you have to take that further. So the cutoffs for the test vary in different labs. So I haven't included that here, but depending on what the cutoff is, and that would be given to you in an MCQ, just know that if it's high, it means it's positive and you need to take those next steps to evaluate this patient. So what do we do with a positive test? Do you guys have any ideas? This is like the last slide. Do you have any ideas? Look in my chat box. What do you do with this patient? Refer to endo. That is definitely the number one thing that I have here is refer to endo. That's exactly what I would do. And what do you think the endocrinologist might do with this patient? Any thoughts? Yes, you're going to do a CT of the adrenals. Yes, great, Kate. Really good. Yeah. And do you guys, just for like bonus brownie points, do you guys know the test for like the actual diagnostic test? You know, when endocrinologists do those fancy tests? Don't worry if you don't. It makes a lot of sense though. Oh, adrenal venous sampling is also on the list. Yeah. So you're right. What we're going to do, if we get a positive or a high aldosterone to renin ratio, we're going to refer to endocrinology, we absolutely will. Now, to confirm the diagnosis, the specific test that they might do, and of course there's always a variety of things, but the main one they might do is something called the saline suppression test. So of course, in health, if you were to give someone saline, you'd give them salt and water. The normal physiological response to that is to suppress your renin and aldosterone because you have so much salt and water, right? So if you give someone in this circumstance this saline suppression test and you don't suppress the aldosterone, then that would be diagnostic of primary hyperaldosteronism. Now, you're right, we do the CT adrenals, and there's a very specific reason for doing this. Do any of you care to tell me why do you do the CT adrenals? It's essential, but there's a couple of things you might see. What are you looking for? An adenoma, yes, an adenoma, absolutely. So the very key thing, you might definitely see an adenoma, you're going to be looking for that, but the key reason to do this, or I guess one of the major reasons to do this, is to actually exclude adenocarcinoma, so a malignancy. Now, usually when you have hyperaldosteronism, it's going to be due to a benign thing. So usually it's due to an adenoma or adrenal hyperplasia, and you might see that on the CT as well. But you want to exclude a cancer, basically, because although it's very rare to have an adrenal cancer, they can be very, very nasty and potentially curable if you catch them early enough. So the key reason to do this is exclude an adenocarcinoma, and then you very well might see this adenoma or adrenal hyperplasia on there. And you guys have quite rightly mentioned that another test that you would do is adrenal vein sampling, but this is a very specific reason why you're doing this. And the reason that you're doing this is because you want to make sure you get the right side, right? Especially if you're planning surgery to remove a gland, you want to make sure you get the right side. And the annoying thing about these adenomas is even in someone who has hyperaldosteronism, and they have an adenoma, it doesn't mean that the aldosterone is coming from the adenoma. That adenoma could be very, quiet, doing nothing at all, and the aldosterone could actually be coming from the other side. So even if you have an adenoma, you can't really tell without doing adrenal vein sampling where that aldosterone is coming from, or you definitely want to confirm that before you remove a gland. So adrenal vein sampling is done by the radiologist, and it is invasive as it sounds, right? They literally go in to the adrenal veins and take blood from them on both sides, and then they compare them. So it's very, very invasive, but it's very important so you don't take out the wrong gland. And of course, sometimes patients aren't appropriate for surgery. And so in that sense, maybe you wouldn't do the adrenal vein sampling and you wouldn't do all that. If you're not planning to remove a gland, maybe not. So you might just do spironolactone and just treat them medically. So it really depends whether it's curative intent or not. But yeah. And so that is aldosterone all sorted out for your exams and doctor life. That was all I had for you guys today. Does anyone have any questions, or I hope you found that helpful. It was super fun. Yeah, fun. And I'll obviously this recording goes up live on YouTube right after, but if there's been any technical issues, I've also made a recording and I'll make it available to you. So thank you so much for coming, my little Zoom room. And if anyone is on YouTube and wants to know how to get into the Zoom room, basically you just have to be on my mailing list, which you can join up over on the website, and then I'll send you if I'm going to do any more lives. I actually don't know if I'm going to do any more lives, but this was really, really fun, so probably. And I'm so glad, Kate. Thank you so much. I'm really glad you enjoy it. And let me know if there's anything else you want me to teach on here, anything else that you need from me as well. All right, I'll see you guys next time. Bye.